Thank you, Mike and Osama, for some phenomenal talks regarding uniportal approach for endoscopic spine and how to get going on this. I think it's extremely important to discuss our journeys and become familiar with how all of you as attendees could advance your endoscopic skills. But that being said, I see that there are a lot of endoscopic surgeons already on this webinar, which is great, and I'm looking forward to actually hearing a lot of your comments. Okay, so these are my disclosures. I consult for Amplify, and that's the dual portal approach. I would say that's the most relevant associated with this talk. So we discussed the uniportal, but dual portal, unilateral dual portal, basically involves two portals of entry, one for your endoscope and one as a working portal. Therefore, I would say this is a little bit more intuitive, especially for all of us that do open procedures. And I would say that the learning curve actually is a little bit easier, at least for me. It decouples the endoscope from the surgical instruments, therefore it provides a little bit more flexibility as well as visualization of the anatomy. Typically, you initially create a pocket of fluid, and you can see your relevant anatomy, such as like the lamina or the facet joint. And after that, you basically place your endoscope in that pocket, and with the working portal, you're able to do many of your aspects of your procedure. So therefore, it's relatively intuitive. Um, I feel I'm kind of harping on what Mike and Osama have discussed. Ultimately, this is, I feel, is the ultimate minimally invasive approach. The patients seem like they have less postoperative pain, better visualization. Infection rate is virtually zero. There is a possibility of also a better fusion rate, especially right through the disc space, because you are able to visualize into the disc space and make sure that you do a complete discectomy, especially when you're doing endoscopic TLIFs. How it's basically decoupling the camera and the working portal, so you're able to visualize the disc space quite better, quicker learning curve since you're using the same instruments as well as techniques. So I started about 1.5 years ago. I'm about 9 years in my practice currently. I started actually in October. I observed Don Park at UCLA. So again, I've always heard about endoscopic spine, and I found a mentor in Don, and he invited me over there. So I was able to observe him doing a few cases, seeing kind of how he approached it. I kind of took notes in terms of what he was doing, and I basically practiced on a cadaver. And you know, I would say that I took the first leap in terms of doing my first endoscopic case with a L4, L5 right-sided foraminotomy. I would recommend actually, if you're going to do this dual portal approach, that you start off on the left side because this first case took me quite a bit of time, uh, just because it was going on the contralateral side. In terms of uh, in terms of that, I did about 4 cases of decompressions before I started doing a TLIF. And then April 2023, I did my first TLIF. I did approximately about 30 more TLIFs as well as decompressions. And then, yesterday, actually, I did a thoracic tumor resection utilizing this approach. So it's been actually a quite quick ramp up phase for me. Relatively quick learning curve. So initially, my first case uh, took about 6 hours, which is a significantly long amount of time for doing a relatively simple procedure that I would say 95% of surgeons could do within an hour. And I've gotten it down to so close to 1.5, 2 hours now. Patients are happy. They're thankful for a minimally invasive approach, no infections or revisions, decent pain scores postoperatively. And I think it's a powerful technique, like Osama was discussing for thoracic discs, but also thoracic decompressions. And then I've done endoscopic cervical foraminotomies as well. I think it's a very powerful technique for that approach. So I wanted to kind of go through a dual portal TLIF and discuss a little bit about the workflow, what's involved with it, and kind of how to plan out the case. First of all, you know, we set up. This is a good, actually a good representation. You have the first thing, the position is your head is up. You're looking at a screen. You don't really have those neck issues that we always worry about as we're doing these cases. Your right hand basically has your working portal. Your left hand has your endoscope. Initially, in this case, we were doing a TLIF approach, and you could see that your endoscope is in one hand, your working portal is in the other. Um, the toughest part, I would say, with this case is that once you create a pocket, is the triangulation. So you have to have some orientation in terms of trying to make sure that both of your instrument tips are meeting. There's some tricks to this. I would say that initially a lot of it is kind of feeling that lower laminar edge and making sure that your camera is there as well as your initial docking port for the working portal. I use basically an Arthrex burner. Um, and that's usually my first instrument because as you go down with your camera, there's going to be some bleeding there. You coagulate and you visualize the lamina. Um, Here we're going into the disk space and we're taking out disk fragments through the dual portal approach. You use your conventional shaver. As you're doing a regular TLIF, and you could visualize as your instruments are going in and out and taking out disk fragments. You size it appropriately, and next, you place in whatever cage you would like to utilize. I use expandable cage in these situations. You can see your cage going in. You could visualize it on one screen on X-ray, and then on the other screen, you could see your cage going in, making sure that you aren't affecting any neural elements. You expand out your cage, and you've already done your decompression. And I basically use some image guidance for this. I place in my instrumentation, my screws in afterwards. And I would say that this workflow actually is relatively intuitive. It's something that it's just for me. It wasn't necessarily a learning curve associated with how to do a TLIF because it's kind of doing the same thing I'm doing in an open approach, but just doing it through through two portals. So it ends up actually being relatively quick, and you have the same benefits that Osama and Mike were talking about, but you have the ability to, utilize the same skills that you use as an open surgeon. So this is that case from yesterday, actually. So it was a thoracic tumor. It was at T12 on the left side of basically left-sided pedicle. It was eating out the left side of the pedicle, causing neural compression. You could see that bone was basically, this is a 62-year-old guy. He has hepatocellular carcinoma, which is a very vascular tumor. This is my first case doing a tumor associated with this. So, and also hepatocellular carcinoma is very bloody. So I had definitely some hesitation before I approached this. Preoperatively, I had my neuroendovascular surgeon, Ali Alraj, actually embolize this. So he embolized it. There were two feeders that were going from T11, T12 on the left side. Ed Amkowitz was going from T10 on the left. So we knew we were sufficiently away from that. After he embolized it, actually, it worked out very nicely. The bleeding was relatively minimal. We used image guidance because, again, this is our first case on this. So we placed a midline small incision where we put our reference frame. And we find the particular line at T11, T12. And we basically at T12, we created a small incision for the working portal. And then about 2 centimeters away, we placed in the endoscope. So again, this is the type of visualization you get. I found the lamina first. After we found the lamina, we basically drilled away the lamina. You could see the thoracic spinal cord here. You could see tumor that's lateral to it. Basically picking away at this tumor, coagulating the tumor, removing the tumor with a pituitary. And also there's continuous irrigation going out of your working portal. So basically the tumor cells are continuously coming out and leaving this area. Uh, this is, as you can see, with the image guidance, which was very nice, we were able to make sure that we were able to take out the tumor actually over to the vertebral body. We're able to clear out actually a decent amount of space of the tumor away from the spinal cord. And then afterwards, we placed in carbon fiber screws for SRS radiation therapy. So this is a good way to do separation surgery and also radiate this patient relatively quickly. So since we just operated yesterday, we're planning on radiating him hopefully in about 3 to 5 days after the surgery. So therefore, he's able to get radiation quickly for the tumor. He's able to get good separation and his pain is better. And also there's not that significant amount of morbidity associated with this. I saw him this morning. He's telling me that his pain is significantly better and his neurological symptoms have resolved. So I feel like this is a great approach, especially for spinal oncology. But again, this is my N of one, my first case. So, I'm not going to hang my hat on it. But I think this is kind of the way I would like to approach a lot of the thoracic spinal tumors in the future. Okay. And this is our x-ray with our carbon fiber screws and rods in. Okay, my final thoughts. I feel like it's using dualPortal is a good working channel for doing a lot of the open procedures that we typically do through a minimally invasive fashion. It was a relatively quick learning curve for me. And it was actually transformative for my MIS spine practice. I would say one other caveat to this. Initially, I was doing decompressions, discectomies, and I moved on to TLIFs. After I moved on to TLIFs, I spent a week in Korea, and I saw kind of the masters in Korea doing cervical foraminotomies, doing thoracic cases, and I saw kind of how they would work with different things like water pressure, coagulation, how they would create a good working portal. And I was able to kind of integrate those into the cases that I'm doing currently. So I think that, initially I was kind of teetering along, but I think I ramped up, with these techniques, particularly after, spending a week in Korea and seeing kind of what a lot of the masters are doing. But I think this has kind of been a very transformative process for my MIS spine practice, and those are my thoughts on this. And I appreciated hearing Osama and Mike's thoughts as well on it.